Excellent. So our next speaker is Elena Cavazzoni. So Elena is a staff specialist working at the Children's Hospital at Westmead in Sydney and is the Co-State Medical Director for Organ and Tissue Donation Service in New South Wales. Clinical lecturer at the University of Sydney Medical School and an honorary fellow in Critical Care and Trauma Division of the George Institute. Elena is a fellow of the College of Intensive Care Medicine, a member of the Royal College of Paediatrics and Child Health, and had a graduate diploma in palliative care from the University of Melbourne. I'm not sure how you lost that, but apparently you did. Her research interests are in organ and tissue donation, transfusion medicine, and neurocritical care.
Thank you very much. And as Ben said, I'd like to thank the organisers for inviting me today here to address yourselves. I was given the task to talk about paediatric organ donation in Australia and New Zealand. I need to disclose that I'm only going to talk about Australia. I'm really sorry, New Zealand, but unfortunately I don't have access to the New Zealand data, or better, in the last 2 months I haven't really tried to get that data. So apologies. Disclosure, number one. And I've been asked to really talk about where to from here. So Ben's given us an amazing picture, and a lot of the stuff that I will touch on, Ben has already seeded the thought within you guys. And I want to really start talking about, why do we talk about organ donation? Well, we talk about it for the recipients. And you might all look and say, oh, isn't that recipient cute? So lovely. That's very true. The recipient was 18 months when she had her liver transplant. She grew up. She went to university. She found her husband. She married her husband and has had her own child. And she's now working as a communication officer within a large company in Sydney. Libby, the mum, was 18 months in 1988, and in 7 weeks, she will be celebrating 30 years of her graft still being present. And when you talk to Libby, and she's very happy for me to show you the photograph of her and Ellie, she actually tells you that her entire life is critically dependent on the generosity of the donor family and of the donor. And I think it's really important because in pediatrics, our transplantation outcomes are really important. Having said that, I need to recognize in my talk, I am talking about the grief of families. So despite saying where to from here, we always need to contextualize the fact that we are talking about family members that are losing their children. So with that recognition, I then just want to move ahead. In 2019 to 2017 was basically 9 years of the National Reform Agenda. And for those of you who have read a lot about the Donate Life articles and activity reports, you'll recognize these graphs. So there's been a 75% increase in actual recipient. And of these recipients, how many of them are pediatrics? Unfortunately, we don't have a national repository that actually indicates how many pediatric recipients have been year on year. What I do know is that at the Children's Hospital at Westmead, where I work, there's been a 172% increase in the pediatric liver transplantation sector. We started off at around roughly 9 to 10 per year before the National Reform Agenda started. And last year we had 30, and this year we're looking at having the same number again. With this, I then would like now to explore two sectors. So where can we grow from here with regards to the donor? And I'd like to maybe present you a different slice to the data that Ben has presented, and then talk about recipients and kind of present similar articles and maybe some new articles with regards to where can small grafts go. Once again, we talk about the National Reform Agenda. We started off with 247 at the start of our national reform, and if we continue to do what we're doing this year, data based to September 2018, projected to the end of 2018, we should have 560 donors, actual donors. That means that for the National Reform Agenda, for the 10 years that we had, we've had an increase of 126 actual donors. And of these, there's been an increase within our pediatric group. So we roughly started off, before the National Reform Agenda, having 7, 6 pediatric cases per year. In 2009, we had 8. And again, projected out to the end of 2018, we should have 24 pediatric donors. That means a 200% increase. And some of you might say, and as Ben mentioned, it's actually a 4% growth. So 4% of the actual growth within the pediatric sphere seems to be followed within the within the donor sphere seems to be followed within the pediatric sphere. And this isn't just an Australian phenomenon. If you actually look at the UK data, it's exactly the same. I don't know why. I have absolutely no kind of understanding of it. But exactly the same. For us, it's been between 3 to 6%, and in the UK, it's been between 4 and 7%. Every year of growth, actual donor growth, the same is in the pediatric. You might say, well, it's just because of teenagers. Just the teenagers. It's a teenager population. They're small adults. That's it. So I asked that question. What I actually saw that if you're less than 5 years of age, we started off with around 2 donors in 2009. And by the end of 2017, but let's also go to projected 2018, that would be 9. Tiny numbers. And this is the second disclosure. First, no New Zealand data. Second, really small numbers. The pediatric sector has tiny numbers. So in most of the data that I'm going to present to you, I'm actually going to be comparing it to the adult world and see what happens in the pediatric sector. Is it reflected or not in the adult world? Again, you might have seen this information. So it's a number of deaths. Oh, no, wrong thing. Number of deaths within the hospital, and then cascading down to the actual number of donors. So within the sequence of it, again, so within this cascade, what we can actually change is our ability to identify the potential donor, to request the potential donor, and to change the consent rates. So what I want to do is unpack a bit of this data. And before I actually take you through the next set of slides, I just want to kind of talk you through exactly what this slide will look like. And this is all data that's provided by the Donate Life audit. So those of you that are donation specialist nurses, I need to thank you guys, because without your daily input into the Donate Life audit, this data wouldn't be available for us. So it's actually not published out there. We hope to actually be able to publish it. But basically, we have the hospital deaths, which is right up at the top. And then within this hospital deaths, you basically pull out the group that had a neurological condition, that didn't have cancer, didn't have HIV, didn't have CPR at the time of death, and that were intubated and ventilated. And then how many of those were actually had a family donation conversation, were consented, and then became actual donors? The requesting rate being the pool versus the donation conversation, the consent rate being the consented patients or families versus the donation request, and the actual donors actually being based on the potential donor pool. And what I did, I wanted to look at all cases in Australia, because the Donate Life audit is run only in Australia, and look at 2016, 17, and projected 2018. So basically, this cascade data works through and sees the number of cases that have happened nationally, and then pediatric less than 16 years of age. So what we see is that in the adult world, the requesting rate is roughly two-thirds. Two-thirds of potential donor neurologic, and these are really the ones that project out to brain death. These aren't the DCD cases. So roughly two-thirds are actually approached by the adult intensive care world. And that's been consistently through the last 3 years. In the pediatric sphere, we actually approach far more, which was the first surprise to me. The second thing was that within the consent rate in the adult world, we've had, certainly a significant improvement in 2018. With consent rates, as Ben had said, 2017 at 59%, that was including the DCD. So for brain death, it was around 57%, and this year projected it's at 65%. In the pediatric sphere, recognizing small numbers, the consent rate hasn't actually been as consistent as in the adult world. And so I just wanted to unpack that a little bit more, and then unpack our conversion rate. And why don't we, for every consented family, why don't we go to donation? And what are the barriers there, and how can we address it in the future? One of the important things, and this was at WithPIC's poster in Singapore, was that when we talk about requesting, families actually have, and this was a group of 20 families, 7 of which were approached and 13 of which weren't approached, and it was an interview post. And what these families said, for those families that weren't approached, at the conversation, at the time of the interview, and I can't quite remember, what was the reason for the interview. I think it was family experiences of end of life. There you go, organ and tissue donation. when they actually were asked, if the fact that you weren't asked, how does that make you, did you care, not care? And the families seemed to say that there was a negative value add. So by not being informed that organ and tissue donation wasn't asked or not thought about, it was almost as if their child wasn't worthy. I just want to put it out there just because a lot of times, and I'm guilty of this as well, we think, oh, we better not breach. The patient is not suitable for organ donation, so we just won't tell the family. But actually, is that the right approach? I don't have the answer to that, but I just want to see the thought. So then the second thing I noticed was that pediatric deaths actually don't just happen in pediatric intensive care units. Surprisingly, they actually happen quite significantly in the adult intensive care units. So what I wanted to do was kind of start to unpack a little bit, because obviously you have adult intensivists dealing with families of small people dying in their unit. And so was there a difference? Do we do things differently between the adult and the pediatric ICU worlds? The requesting rate is very similar. Again, totally acknowledging the small numbers. I totally get it. But the requesting rate is very similar. The consent rate, though, seemed to be different in that there seemed to be, again, really small numbers. So I wanted to understand what was that difference. And so I explored that a little bit more. So basically, that was projected data. I'm now actually going to give you data from the actual conversations. So between the 30 months, between the start January 2016 to June 2018, there basically been 154 conversations in pediatric ICUs and 37 conversations in the adult intensive care world. The number of times that donation was raised by the pediatric staff, or by the staff in the intensive care unit, was roughly half to 60%. And I'll show you adult data in a second. The other rest of the time, it was actually family raised. So it's either staff raised or family raised, which starts asking the question, is it because the families of small children are actually more aware of organ and tissue donation, and therefore they're raising it more frequently? The second thing was that in the pediatric sector, of those conversations where it was raised by staff, only 18% were done as a collaborative, versus 54% that were done as a collaborative in the adult intensive care unit. And when we do it in a pediatric intensive care unit as a collaborative model, we actually have a 67% consent rate. And if we don't do it as a collaborative model, we have a 33% consent rate. And I know, I hear you, it's small numbers. So let's see what happens in the adult world. Sorry, before I do that, the other question I had was, well, the adult world, they're only going to have teenagers dying in their intensive care unit. So it's a different population from our 1 to 2-year-olds. And so we plotted out the age of the patients dying in the adult intensive care unit and the pediatric intensive care unit. And what we saw was that there's pretty much an even spread. What happens in the pediatric world happens in the adult intensive care unit. It's just much smaller volumes. So then I wanted to look at, what about in the adult world? So excluding all the less than 16 years of age, for the same period, 30 months, we had 2,482 conversations. Of those conversations, 75% of those conversations were staff raised, which means, I don't know, maybe in the adult population, there's less thought about organ and tissue donation, maybe because the 89-year-old brain-dead granddad in the bed is not seen as a potential donor by the family. I don't know, just one explanation. The rate of collaborative requesting, having gone through and being the state medical director, we go through data from other jurisdictions as well, and we kind of pore over this data. You have to love statistics to do the job that I do. But the rate of collaborative approach in the adult world has actually only increased in the last 9 to 18 months. More and more, the adult intensive care units have actually started to embrace the collaborative approach. But overall, during that 30-month period, 26% of those conversations raised by the staff were done as a collaborative approach. And the consent rates were kind of similar, particularly if not done collaboratively, there was a 33% consent rate. What does this mean? Well, I want to take you back to that paper that Ben talked about. And as he said, yes, it did show, the final conclusion was that the collaborative approach was not statistically significant. That was done with an intention to treat analysis. If you actually look, though, and explore a little bit more about the actual data, what you know is that out of the 201 conversations, 101 done in the routine and 100 done in the collaborative approach, what we actually know was that in the routine group, there was actually far more people that were actually on the donation registry. And in the collaborative group, there were actually far more pediatric patients. And when you actually and there was far more violations in the collaborative group because there were far more family-raised conversations in the collaborative group. So therefore, they couldn't actually perform the protocol as collaborative. So if you do a protocol analysis, you notice that there was a 67% consent rate in the collaborative group versus 60% consent rate in the routine group. Again, small numbers. Is it statistically significant? I doubt it. So if you come to our shores in Australia, in 2008, sorry guys, they talk a lot. In Australia, in 2008, there had been a collaborative approach, which precedes the Organ and Tissue Authority, or Donate Life. And what we know is that the Royal Melbourne truly embraced the donation specialists and entered the donation specialists squarely within their intensive care unit. And what they saw was an increase from 50% to 75% within the 3-year period of the collaborative. What we know now from the Royal Melbourne is that they do all their requesting collaboratively. And the Royal Melbourne, I was speaking to one of their colleagues at the start of September, they had 41 actual donors from the Royal Melbourne. That is an astonishing number of donors from a single centre, from a single unit. In 2015, there was also this paper here that basically looked at a modelling, which from this paper we then have our best practice guidelines that was published in 2017. And basically from this paper, and it was done, 12 months, 15 hospitals across Australia and New Zealand, looking at different approaches. And what we saw was that if you had a collaborative requesting approach, treating intensivists plus the donation specialist, you had a 75% consent rate. And that dropped down to 45% if you actually had the the intensivists just running the conversation, not having done the family donation conversation core workshop. They then did a multivariate regression analysis, and there were 3 things that came out. So the decision of consent basically boiled down to 3 things. Was the individual on the AODR? And as we've just heard, obviously the pediatric world, it's mute for us because we don't actually have any registration within the pediatric sector. Is it appropriate? Is it not? It's not my place to say. The second thing was it changed the outcome if you performed it as a collaborative. And finally, there was a small signal with regards to decoupling the conversation between death and organ and tissue donation. So from that paper, that best practice guideline was published in 2017 in June. But actually, it's not just us in Australia that's come up with this. It's not like we've reinvented the wheel. In 2013, the blood and transplant, NHS group, published exactly the same guideline about how to approach families. And once again, their messaging was, do it collaboratively. And in the UK, they've got increased consent rate with increased collaborative model embracement, shall we say. And in Canada in 2014, they published exactly the same. We're all basically writing the same thing, just for our own sectors. But the messaging is always the same in all of these 3 guidelines. And I take out these 3. I don't really want to go into the States because the States has such a different healthcare provider system than we have. But if we look at the UK and Canada, they're probably the more similar ones compared to the healthcare providing systems that we have here in Australia and New Zealand. I want to now change tack. I'm sure you're all bored of hearing about the collaborative approach. So let's change tack and think about why do pediatric cases actually not progress? And if we look at the main reason between 2016, 17, and 2018 was basically we couldn't find a suitable recipient. And therefore, the patient didn't proceed to donation. If you look at data from 2015, you actually find, and this paper basically looked at just kidneys. And it kind of stratified them between less than 2 years of age, 2 to 5 years of age, and greater than 5 years of age. And I apologize for the term, but the utilization rate from those that were less than 2 years of age was far lower than those that were between 2 and 5, which were Group B, and greater than 5, which were Group C. So I now want to spend the rest of my time really talking about where can these organs go? Who are the most appropriate recipients? I'm not going to talk about the liver crew because I do know that the liver transplant team are certainly embracing small donors. We've had a 75-gram liver that was transplanted into a 10-monther. This was several years ago, and the 10-monther is now a toddler doing well, running around. And that was from a 36-weeker who was 2.2 kilos at the time of donation and was brain dead. So I don't really want to talk about the liver guys. I don't really want to talk about the lung guys because I don't really know them. Sorry, guys. So I'm just going to sit between the kidneys and the hearts, which is really the conversation that Ben's had with you just before. So this is a paper that was published in 2013, and it's from a German group. And basically what they did is they reviewed data from 7.5 years, looking at different size donors from 2.5 kilos to 15 kilos, and looking at where these grafts actually went. And it was either a single graft into a pediatric, an en bloc, so 2 kidneys plus a little piece of bladder into an adult, or as a single kidney donation into an adult. And ultimately what they found was that despite acknowledging early graft loss, ultimately the end outcome for all these recipients was equal. And that early graft loss could be minimized if we actually centralized our patient management to a couple of units, which is what the UK have done, having the leads crew and the guys managing small grafts. There's also this paper that's just being published, which basically reviews the data, because as Ben said, there's a lot of data. There's a lot of kind of ad hoc, 130, 130, just kind of sporadic experiences. So they basically collated the data from 25 centers. And what they found was, just like the Germans, that despite early graft loss, it is appropriate to consider small pediatric grafts for small pediatric patients. And in Australia, this year, we've actually had the first pediatric DCD of a child who was less than 5 years of age that went into a less than 10 kilo child. And the kidney did incredibly well straight away, and the child is doing really well, the recipient. And they were really challenging circumstances to actually agree to do this. But it was either this or the child potentially could have suffered significant consequences had the child not received a transplant. So despite working, I'm not a pediatric transplant nephrologist, so I don't really want to tell them how to do their work. But again, I think we just need to acknowledge that this data is out there. But we also need to acknowledge that it's not just the pediatric sector that can benefit, but it is also the adult sector. And so this is an article, again, published in 2018, looking at grafts from less than 10 kilo donors. And once again, interestingly, grafts from less than 5 kilos, less than 10 kilos, by the time they get to 3 weeks of age, there's been enough hypertrophy to actually have to be similar to those greater than 10 kilos. And if you look at the outcome of these grafts, they're relatively similar, being followed up for, I think they did between 44 and 124 months in this study. And then, obviously, it's a paper that Ben talked about, which is the Leeds crew. And again, they look at good outcomes with acknowledgement of early graft loss, in that they had 2 nephrectomies that they had to do within their population set. Finally, this is a St. Vincent's crew, which Ben has talked about. And we do know that a child who's on the heart transplant waiting list, a neonate who's on the heart transplant waiting list, has probably got the highest mortality rate of any other group waiting on the transplant waiting list. And we do need to remember the case of Denver, where 3 neonates were taken down the DCD pathway, and their end-of-life protocol was changed to fit the needs of the recipient. And I think this was probably the breaking point, the time where the pediatric intensive care crew basically lost trust in the transplant crew. So we have to be cautious and we have to have gold standards. And in Canada, in last year, they actually published this Canadian Guidelines for Controlled Pediatric Donation After Circulatory Determination of Death. It is a 68-page document. It is a fascinating document. It is really, really good for those of you that want to read this kind of stuff. And so, although we do talk, and I regularly talk to Peter MacDonald, and I always say to him, Peter, where is my paediatric, organ care system? And the Australian crew were the first ones to actually design one. Hopefully, we can be in the leading edge of actually creating a DCD pediatric heart program with the acknowledgement that we need to make sure that we respect the donor and the donor family, and we keep them at the forefront of everything that we do. So my take-home messages are simple. They're just three. The collaborative approach should be routinely considered in the pediatric intensive care units. PICU should continue to work collaboratively with the transplant world and see how can we best allocate these grafts. Where do these grafts go? And finally, we need to push the technical barriers to ensure that we are able to continue to provide care to the patients and families. I finally just want to acknowledge Libby, who was the lady that I introduced to you at the very start of my talk, all the donation specialist nurses, and there's one near you, one in a hospital near you, and Mark MacDonald, who's basically provided all the data that I presented to you today. So, unfortunately, it's not published data, but hopefully we will be able to publish it soon. Thank you.
Beautiful. Thank you very much, Elle. Unfortunately, we don't have time for questions, so I think you knew that was coming.